Today, our session is entitled Living Well with Restorative Care. I am Susan Slaughter, a member of the Provincial Board of the Alberta Association on Gerontology, and today I am your host. Before we start, I would like to go over a few housekeeping details. We are using Zoom webinar technology, so everyone is automatically muted and you will not be seen on camera. With the approval of our speaker, Grace Maier, today we will be recording the sessions, but your names and private information will not be shared. You will receive a link to the recording, which can be shared with others, but you'll not receive any copies of our slides. You'll see the slides in the recording. If you're having any difficulties, you can type a message in the chat box and we are going to do our best to respond. If you have questions, and we welcome your questions, please use the Q&A box to send your questions to our speaker. Grace will talk for about 15 to 20 minutes, and when she's finished speaking, we will address as many questions as possible in the 30-minute session that we have today. So without any further ado, I am going to introduce Grace Maier to you. Grace's background includes close to 40 years of experience in seniors' health services, continuing care, and rehabilitation. Grace joined the Glenrose Rehabilitation Hospital in 2001. This portfolio includes inpatient and ambulatory geriatric assessment and rehabilitation, cognitive assessment and rehabilitation, and geriatric psychiatry. Grace is a certified health executive of the Canadian College of Health Leaders, and she currently serves on the provincial board of the Alberta Association on Gerontology. Grace has strong relationships with other sectors along the healthcare continuum, the City of Edmonton Seniors Initiatives, and seniors serving organizations. These initiatives include things like accessible housing guidelines, the importance of activity and early mobilization to prevent functional decline. So I'm going to hand it over to Grace now.
Good. Thank you so much, Susan. Really appreciate everyone being involved today. And I'd first of all just like to thank Susan as well as Hedong Leong for their support in the content of this section of the policy paper that AAG has put together. And I'd like to thank all of you for participating in our speaker series. This is the 4th of 7, and it's been definitely a privilege to be involved in this work, and really exciting to see the level of interest and engagement of you, our audience. So really appreciate that. Okay, this is our vision for senior services in Alberta, our 2030 vision. And you may have seen this before if you were involved in any of the other sessions, but for those of you who may not have been, I wanted to make sure that you had this context. The Alberta Association on Gerontology started the process of future planning in the Vision 2030 Symposium, which was held back in November of 2019. This vision statement was the overwhelming consensus of those who participated in the symposium, as well as by those members of focus groups, which were held throughout the province prior to the symposium. I'd also like to express appreciation to Vivian Lai, our past president of AAG, for her initial vision of doing this work, and for Linda Stanger, our current president of AAG, for her steadfast support and passion in continuing this initiative. So thank you so much for that. AAG involved a number of stakeholders in formulating the recommendation and has become actively engaged in discussions with Alberta government on how to bring these recommendations and actions to fruition. The full policy document is available on the AAG website and contains directional policy recommendations and immediate action recommendations on a number of areas important to seniors' wellness, all of which are being covered in the presentations of our Living Well speaker series. Just as an aside, this vision that was developed for our 2030 vision is certainly in alignment with a report that is fairly recently put out by the World Health Organization on a decade of healthy aging. That report speaks to the importance of older persons' well-being based on functional ability, intrinsic capacity, and environment. And the functional ability includes the important domains of abilities to meet basic needs, learn, grow, and make decisions, be mobile, maintain relationships, and contribute to society. Before we talk about restorative care, let's talk about the importance of activity for older adults. Again, the World Health Organization, in their 2020 guidelines on physical activity and sedentary behavior, include high certainty evidence which demonstrates that balance and functional exercise reduce the rate of falls, and different types of physical activity helps to improve a number of elements of physical function. There is also moderate certainty evidence that the multi-component physical activity that includes balance, endurance, gait, and strength training reduces falls-related injury. As such, the World Health Organization recommends that older adults do multi-component physical activity at moderate or greater intensity at least 3 days per week. Better mobility status and leisure activity not only support physical well-being, but are also associated with mental well-being among older adults based on factors including depressive symptoms, anxiety, loneliness, self-rated mental vigor, and life meaning. Physical inactivity, on the other hand, has been associated with statistically significant increases to hospitalization, longer lengths of stay, and healthcare visits. Some studies suggest that a 50% higher healthcare cost are realized for those who are physically inactive as compared to those who are physically active. Up to 65% of older adults independent and walking prior to hospitalization will lose their ability to walk during a typical hospital stay. Without mobilization, older adults can lose up to 5% of their muscle mass due to bed rest. 1/3 of these individuals may develop a new disability in an activity of daily living during hospitalization. Half are unable to recover previous function, resulting in a loss of independence, medical complications, caregiver burden, increased mortality, and premature institutionalization. The hazards of immobility can settle in less than 24 hours of bed rest, and these include a number of physiological changes, which are very clearly illustrated in this diagram developed by the Move On initiative in Ontario. The impact of COVID has certainly worsened the impact of immobility on functional decline, especially for older individuals with multiple comorbidities. It has been described that COVID patients coming out of ICU are quote unquote functionally quadriplegic. The plan of care for post-COVID recovery over older adults will need to include mobilization and rehabilitation, considering their often compromised pulmonary capacity. It will be important for us to capture this evidence through retrospective reviews of hospitalized COVID patients, including patient outcomes. Social isolation within community dwelling seniors and congregate living settings as a result of COVID has also resulted in less activity and the associated decline in muscle mass leading to functional deterioration. This social isolation has certainly also resulted in a negative impact on cognitive and mental well-being. Let's turn our attention to restorative care. Optimal wellness for older adults includes physical activity encompassing a restorative care approach. Restorative care is a philosophical approach to care that focuses preventing functional decline and restoring and maintaining optimal functional and physical status. This philosophy supports a care approach that prevents or minimizes a decline in activities of daily living and maximizes physical abilities. In a restorative care bedded program, for example, in a hospital or a post-acute setting or continuing care, the focus is on an individualized goal-oriented plan of care to improve mobility, physical function, and activities of daily living while normalizing daily routines, helping individuals do for themselves and maximizing their abilities rather than their disabilities. A restorative care philosophy can be implemented wherever the person is situated. In addition to tertiary rehabilitation, a restorative care approach has been demonstrated to be effective with older people living at home in the community, in assisted or supportive living, in long-term care, in acute hospital, and post-acute transitional care. While the desire is to minimize the need for acute hospital care, those services are indeed required for older adults on an episodic basis to address exacerbation of chronic illness, an acute medical event, acute functional decline, or traumatic injury. Acute hospital care may be followed by rehabilitation in a tertiary setting, so it's also crucial to include a restorative care philosophy in acute hospital settings. And as mentioned, a restorative care philosophy can be implemented wherever the person is situated, whether it's tertiary rehab, at home, in assisted or supportive living, in long-term care, in hospital, and post-acute transitional care. There are a number of pragmatic restorative care approaches that have been tried and true around the world. Denmark was the first to jump on the bandwagon with one of the first to adopt a restorative care approach. Capital Care developed a restorative care approach which resulted in an 88% improvement in functional gains. Long-term care research at the University of Alberta, and Dr. Susan Slaughter was certainly a key player in this. In fact, was the PI on this research work. And in that research, they looked at the sit-to-stand activity implemented by healthcare aides. And residents benefited from activity, and with as little as 1 minute of sit-to-stand activity 2 times a day, and mobility was maintained or improved for 4 out of 5 residents. And the YouTube video, it can be accessed through this URL, and it's excellent. It's only about 90 seconds. We won't take the time to show it today, but please on your own give that a look. The United Kingdom, also the NHS has initiated the End PJ Paralysis movement, and that saved over 700,000 hospital days. And that initiative has also been adapted in the Alberta environment as well. In a Calgary pilot, they recognized that or observed that 68% of individuals involved in the pilot were mobilized. In patients over the age of 65, there was a reduction in length of stay of anywhere from half a day to 7 days compared to the same time of the previous year. And this illustration or this screen view is from the Insight, but there's also an external Alberta Health Services website that I have included at the bottom of this slide that indicates where you can go for additional information. So the NPJ paralysis movement is really emphasizing the need to get patients out of their pajamas or out of their hospital gowns and increase their activity. And I think we could probably parallel this this feeling of being in your pajamas and the reduction in the desire to do any kind of physical activity. And the parallel being that during this phase of COVID, I think we probably have what we might call a sweatpant paralysis, where, you know, if we've been working at home, we probably aren't as engaged in the level of activity that we might otherwise be if we were out going to work and carrying on with our daily lives. So the Ending PJ Paralysis campaign is grounded on two primary goals: ensuring respect and dignity in care by encouraging patients to bring in their own clothing while they are in hospital, and then preventing hospital deconditioning, both physically and psychologically, by supporting and encouraging patients to stay active while they are in hospital. So as with all of the other areas in the paper, we have developed some directional policy, and that is for all health services in Alberta to implement a restorative care philosophy across the care continuum, and that all seniors community services in Alberta promote active living and programs to mitigate sedentary behavior. Special attention should be given to addressing the impact of social isolation and the sequelae of reduced activity during outbreaks on activity levels of older adults. And how we would see that implemented is illustrated in this diagram. So all healthcare providers, students, and volunteers can support increased mobility in older adults. The integration of a restorative care practices into the education of direct care providers offers a strong foundation for use of these practices in day-to-day person-centered care. Adoption of best practices, including initiatives such as in PJ Paralysis, home exercise programs, and restorative care across the continuum of care and in the community, building on and spreading learnings from successful pilots and initiatives, have already been conducted, and we just need to spread those learnings. Organizational incentives need to support this care approach in healthcare, continuing care, and community. This may require a review of resources, since supporting activity independence often takes more time initially than simply doing for the older adult, but that can pay off in the older adult being more independent and relying less on the staff to support their care needs. So for immediate actions recommended for 2021, we are suggesting that a multi-sector task force be established, which would be inclusive of, but not limited to, educational institutions, healthcare and community agencies, to develop a provincial restorative care policy and a provincial strategy that would promote active living of older adults. A provincial strategy would involve key stakeholders for scale and spread across the continuum, and a task force with key deliverables, including a restorative care framework, education, equipment, and creative strategies to mitigate hazards of sedentary behavior. And that's my presentation, and I would certainly welcome any questions that people might have, and I'm going to turn it back over to Susan to support the monitoring of the Q&A box, and we'll try to address your questions as best we can.
Thanks, Grace. That was great. A really concise presentation, which allows us now to answer some questions that have come forward. One of the questions pertains to, well, actually, a couple of the questions pertain to the current pandemic. And so here's the first one. With quarantine and outbreak in long-term care, it's been difficult during these quarantine times and outbreaks. Will there be shorter times and duration of the quarantines considered? So the question is, will shorter times be considered and duration times be shorter? So it's a concern about the limitations of mobility during quarantine in long-term care.
Right, right. And I can't address that specifically. I'm certain that Alberta Health and Alberta Health Services are considering those kinds of things. But just, from personal experience and knowing those who are in continuing care settings, certainly there's been, some give and take around those quarantine rules based, if we compare to the beginning of the pandemic. And at the beginning of the pandemic, there was so little that we knew about it, and I think the measures were very strict to support um, the the mitigation of a potential transmission. Um, but certainly, I think over time we've seen the consequences of isolation on individuals, and certainly there needs to be a balance of safety from an infection prevention perspective and safety and well-being from a social interaction perspective. And hopefully with the advent of the vaccine, that will support the ability to have increased social time with family members and so on. So I think stay tuned for that. As I said, I'm sure Alberta Health and Alberta Health Services are definitely looking at that.
Okay. The next question has to do about acute care, again related to the pandemic. And the question is it possible to reduce the impact of the pandemic in hospitalizations of seniors who are waiting to get into long-term care?
Again, I probably, would want Alberta Health Services to respond to this. I think most people know that there are CMOH orders about people returning to long-term care. Again, just to help avoid the transmission of the virus. The safety of the multiple people in congregate settings is of utmost importance, and I think all the measures are in place to prevent that transmission.
We've had a few people offer some comments. One person has suggested that if a resident tests positive, the contact droplet isolation is 28 days. And then there's another comment here, and it says that she has seen negative results of quarantine and isolation in her mother's mobility and cognitive ability. And while we may need to limit interaction with the outside world, we probably need to increase the staffing inside the facility to improve daily mobility. This work with the resident is easily done if we could provide the manpower.
Yes, yeah, and that's a really, really important point. And I think probably continuing care facilities have really learned that throughout the pandemic, is that isolating seniors and the inability to keep them mobile and active during the pandemic has certainly had consequences on their physical function, as well as their well-being and cognitive function. Because they have, had very little social interaction. I know that there's been concerted efforts at hospitals and in continuing care settings to really support as much as possible that virtual visit with family members. Now that addresses the social isolation piece. It doesn't necessarily address the activity piece. With the pandemic, of course, we congregate settings and hospitals often can't have group activities or very limited group size. So sometimes those exercise programs have to be deferred. But if, as the person posing the question is suggesting, if there was additional resources to support more perhaps one-on-one activity, that would certainly support individuals.
So there's been another suggestion by a participant. Many senior centers have calling programs, online social support and exercise programs. And there are programs whereby seniors can get a free device, very cheap on the internet, and one-on-one training over the phone for free. And the comment was that that's available in Edmonton.
Wow, that sounds fantastic. If that person could put something in the chat box to share or send it into my email address, I would love to be able to share that. That sounds like a fantastic resource.
Mm-hmm. And there was a question about the Denmark approach that you referenced earlier. Is the restorative care approach used in Denmark providing ongoing positive results that maybe could support an initiative here? And do we have any information on what worked well in Denmark and what to avoid or to do differently? Learning there, could we benefit here in Alberta?
For sure. And we certainly have referenced that work in our full policy statement. That reference is provided, and I would encourage people to look at that reference list to get that information. And
Okay.
absolutely, we should always be learning from where programs have been implemented elsewhere.
So we have a question. Do you have any suggestions on how to promote activity in older adults in the community during the pandemic? These folks may not be at greatest risk of going unnoticed for functional decline and isolation.
Yeah, and I think the person that suggested the home exercise program and the device, I think that's a fantastic resource. I know, with family members, in my own experience, encouraging them to go out for walks when it's safe to do so. I know during the winter time it's not always been easy because of the ice conditions and so on, but with the one or two essential visitors that people in the community are able to have, if that visiting time could be spent in some sort of activity, whether it's walking or just doing even the sit to stand suggestion that was mentioned in the U of A research, even encouraging people to do that while they're sitting and visiting, I think is always a good idea. We have to be creative about the kinds of things that we think about in getting older adults engaged in different kinds of activity and just keeping active.
How do we get the message out to older adults in the community that there are risks from being sedentary during the pandemic, such as poorer outcomes, more hospitalizations?
Yeah, that's a really, really good point. And it's with all the work that I've done around the importance of physical activity and mobility, it's always difficult to reach those people in the community to emphasize how critical it is, because as we age, we naturally lose muscle mass, and that is so important to balance. And balance, of course, is important to prevent falls. But sometimes people don't recognize that regular physical activity on a day-to-day basis is really going to help them. And I think senior centers have certainly played a huge role in that, and have really supported that kind of awareness amongst older adults. But I think, even more public health campaigns and more awareness of that is certainly important. I know there's been a real focus too within the city of Edmonton on making senior friendly or user friendly paths, making sure that places are accessible so that they are user friendly for a wide range of our population, both older people and younger people.
So we have a person who's been a participant suggests that the Edmonton seniors and West End seniors have free online classes geared to seniors. And they also have seated exercises that are on demand via YouTube. We have a question. This will be the last question. Can you share strategies on engaging regulated professionals to influence this restorative care approach? Allied health, physicians, regulated nurses. Any recommendations on where to start?
It's definitely a multi-pronged approach. And, within the hospitals, I think it's emphasizing that it's not just physical therapists and occupational therapists that are key to promoting activity amongst hospitalized patients. It's everybody's role, nursing, physicians, everyone. I know that there's physicians, family physicians in the community that have a prescription for activity, which encourages people to get out and be active. And again, I think there's, a balance between safety. Sometimes people feel that if people are mobilizing while they're ill, that might not be a good thing. And in fact, the opposite is true. And I know that there's been lots of initiatives, particularly in surgery areas where early mobility is really critical to help in the healing process of individuals. But it's definitely a multi-pronged approach. And I think that education of clinical providers is key to help them understand the importance of physical activity and mobility throughout that continuum of care, and even before a person enters a care environment.
Okay, well, Grace, you've done an amazing job in covering a lot of material in a short time and allowing us to engage with questions and comments with our audience. And I want to thank you for that. I've just put in the chat another suggestion, another contact that can be shared regarding internet reference. So now I am going to say thank you to everyone who's participated today. And I want you to recall, you will receive a link to this recorded webinar. And at the same time, you're also going to receive an evaluation survey in that email. We hope that you will respond so that we can improve what we're doing, because we still have several sessions left to go and we're modifying what we're doing as we go. And then also consider registering for next Thursday's session entitled Living Well with Dementia. So on that note, I'm going to say goodbye.
Thank you, everyone.
Thank you.